بسم الله الرحمن الرحيم. طلبتنا الأعزاء، السلام عليكم ورحمة الله وبركاته. أنا دكتور فالح وحيد. Our lecture today is the anatomy of the knee joint, which is prepared by the module staff. We have 5 learning objectives. We try to discuss these objectives during the next slides. And the knee joint, actually, it is the largest and the most complex joint in the body, and 3 bones involved in the formation of the knee joint. It is the lower end of the femur, upper end of the tibia, plus the patella, and the fibula is not a part of the knee joint. And there are two joints in the knee. First one between the femur and tibia called femorotibial joint, which is a synovial hinge joint. And the second joint is between the patella and the femoral condyles called patellofemoral joints, which is a synovial gliding joint. So we have two joints in the knee forming this joint, which is, as I said, one of the most complex joint in the body. This is simple picture showing the two joints. First one is the tibiofemoral joints between the femoral condyles and the tibial condyles, and the second joint is between the patella, the articular surface of the patella, with the femoral condyles forming the what is called the patellofemoral joint. Now we come to the capsule of the knee joint. The capsule is attached to the articular margin and it encloses the knee joint posteriorly and laterally, but the capsule is absent anteriorly, permitting the synovial membrane to pouch upward beneath the quadriceps tendon, forming what's called the suprapatellar bursa. So this is peculiar for the knee joint. The capsule does not encircle the joint fully, it is absent anteriorly. Regarding the stability of the knee joint, as you see, the shape of the bone make the rule of the bone in the stability of the joint is weak, so the stability depends mainly on the muscles and ligaments. In general, the stability will depend on bony factors اللي هي weak stabilizer, ligament factors, muscular, and we have a special situation has a role in the stability of the knee joint. This is the bone, as you see, this is the femoral condyles, this is the medial lateral femoral condyle, and these are the tibial condyle, and you see there is some mismatch between the femoral and tibial condyles. How this mismatch is solved? Need to deepen the tibial plateau to accommodate the femoral condyle, and this is the function of the menisci. We will see it in the next slide. The ligaments are important stabilizer in the knee joint, and they are divided into those that lie outside the capsule, semi-extracapsular ligament, and there is a group of ligaments within the capsule named intracapsular ligament. Regarding the extracapsular ligament, we have four: ligamentum patelli or patellar ligament, medial and lateral collateral, oblique popliteal, and arcuate ligaments. These are the extracapsular ligaments of the knee. The intracapsular ligament, also there are four: anterior cruciate ligament, posterior cruciate ligament, meniscofemoral ligament, and the transverse ligament. These are the main ligaments of the knee joint. First ligament اللي هو extracapsular is the patellar ligament, which is actually the distal end of the quadriceps tendon, and it is inserted into the tibial tuberosity, and actually it supports the knee joint anteriorly. It is a strong ligament. Second ligament is the fibular or lateral collateral on the lateral side of the knee. It is cord-like, strong, extend from the lateral epicondyle of the femur to the lateral surface of the head of the fibula, and its uh, role is stabilizing the knee joint laterally. The medial collateral ligament is another extracapsular ligament. It is weaker than the lateral, and it is extend between the medial femoral epicondyle to the medial tibial condyle and the superior part of the medial surface of the tibia. Its middle fibers is attached to the medial meniscus, and this has some clinical importance. It stabilizes the knee joint medially. So these are the medial and lateral stabilizers of the knee. The another two ligaments, extracapsular ligament, the oblique popliteal ligament and the arcuate ligament, they are support the knee posteriorly. The oblique popliteal ligament, actually it is a thickening of the tendon of the semimembranosus, which support the knee posteriorly, and also the arcuate ligament is also support the knee posteriorly. Regarding the intracapsular ligament, we have the anterior and posterior cruciate ligament, which are two strong ligaments that cross each other within the joint cavity inside the capsule. They are named anteriorly and posteriorly depending on its tibial attachment. Attached anteriorly in the tibia, called anterior cruciate ligament, will attach to the posterior aspect of the tibia, named posterior cruciate ligament. Actually, they are the main bond between the femur and tibia throughout the joint's range of movement. The anterior one is weaker than the posterior, and it is attached to the anterior intercondylar surface of the tibia. This is the anterior cruciate ligament, attached to the anterior intercondylar surface of the tibia distally, and go upward and laterally to be attached to the medial side of the lateral condyle of the femur. Its function prevent the femur from moving backward on the tibia or prevent the tibia from moving forward on the femur. The same. The another cruciate is the posterior cruciate ligament. Distally, it is attached to the posterior intercondylar surface of the tibia and go upward and medially to be inserted to the lateral surface of the medial condyle of the femur, and it is prevent the femur from moving forward on the tibia or prevent the tibia from moving backward on the femur. As summary, the collateral ligaments prevent excessive medial and lateral displacement أو احنا راح نشوفون نسميها varus and valgus. The anterior cruciate ligament prevents hyperextension of the knee joint and posterior displacement of the femur or the tibia, and the posterior cruciate ligament prevent hyperflexion of the knee and excessive anterior displacement or movement of the femur on the tibia. The another important stabilizer, it is the muscular factor, which is very important. On the top of the list is the tendon of the quadriceps muscle that stabilize the joint anteriorly. One of the important things you should look for is the orientation of the distal fibers of the vastus medialis muscle. You see, there is transverse orientation of the fibers of the vastus medialis, and this is important to support the patella and to prevent its displacement laterally. You see, the fibers of vastus medialis run transversely toward its insertion in the patella. The another muscular stabilizer is the iliotibial tract, which stabilizes the slightly flexed knee. This is the iliotibial tract, which is a site or continuation for the insertion of the gluteus maximus muscle, which go downward to be inserted into the what is called Gerdy's tubercle on the lateral aspect of the lateral tibial condyle, which is an important stabilizer for the knee joint. The another stabilizer is the two fibrocartilaginous plate اللي هي الميديال and lateral menisci. And here the peripheral border of the menisci are attached to the capsule, while the inner border are thin and concave, and it has free aids. So the attachment of the menisci are at the periphery to the capsule. They function to deepen the articular surface of the tibia. As I said in the previous slide, there is a mismatch between the femoral and tibial condyle. How this solved by the menisci, which deepen the articular surface of the tibia to accommodate the femoral condyle, plus they are shock absorber during the activities of daily living. The medial meniscus, its shape is C-shaped, and they are attached to the intercondylar area of the tibia anterior to the attachment of the cruciate ligament. And the medial meniscus laterally, it's firmly attached to the tibial collateral. You see, this is the medial collateral attached firmly to the periphery of the meniscus. And what does this mean? This is mean if there is a trauma causing damage to the medial collateral ligament, it's almost invariably associated with damage of the medial meniscus, and this is make the mobility of the medial meniscus is less than that of the lateral meniscus. So the medial meniscus is more vulnerable to injuries in comparison with the lateral one. The lateral meniscus is smaller and almost circular and more mobile than the medial. The cause for that because the medial meniscus has firm attachment to the medial collateral but not to the lateral meniscus. The posterior part of the meniscus, of the lateral meniscus, attached to the femoral condyle by a ligament called meniscofemoral ligament. This is the meniscofemoral ligament attached between the posterior aspect of the lateral meniscus and the medial femoral condyle. The two menisci connected to each other anteriorly by what is called transverse intermeniscal ligament connect the anterior two horns of the menisci. These are the ligaments, the intra and extracapsular ligaments are, as I said, they are the main ligaments that supporting the knee joints in addition to the muscular factor and the menisci. In addition to the ligaments, muscles, we have special situation also important for stability. This is called a normal or physiological locking of the knee. Here, when the knee is fully extended The foot, with the foot on the ground as in standing upright, the knee will be locked. This is a normal locking of the knee. So when the knee is fully extended by the function of the quadriceps muscle, the quadriceps is the extensor of the knee. When the knee is fully extended and the foot on the ground as in standing, especially when you are concentrating on something, during standing, the knee will be locked. How locking happen? Simply, the medial femoral condyle, you see the anteroposterior diameter is larger than that of the lateral condyle. So, so there is a medial rotation of the femur on the tibia occurs until the major ligaments twist taut, effectively locking the knee into a rigid structure. You see, the femoral condyle medial is anteroposterior diameter is larger than that of the lateral. So when the knee is extended, the whole articular aspect of the lateral condyle is included, but the medial is not. So to involve the whole articular condyle of the femur, this is need to rotation of the femur medially, and this is medial rotation of the femur on the tibia will make the ligaments, major ligaments taut and locking the knee into a rigid structure. When you want to flex the knee, the first point is the unlocking, which is mean lateral rotation of the femur on the tibia and semi-unlocking, which is the function of the popliteus muscle. So the locking is a mechanical property for the knee joint, which is helpful to keep the knee extended for a long time without muscle fatigue. These are the movements of the knee. The main is the flexion and extension, and there are small degree of rotation, medial and lateral rotation, and these are the muscles responsible for these movements. Now we come to the synovium of the knee joint. The synovium line the inside of the capsule, and it is attached to the articular margin, and it is extend superiorly, forming the suprapatellar bursa. This area is devoid of capsule, but there is synovial pouch between the quadriceps tendon and the femoral bone, forming a bursa called the suprapatellar bursa. This is point the cruciate ligaments and popliteus tendon, although they are intracapsular, but actually they are lie outside the synovium. So the cruciate ligaments and the popliteus tendon are intracapsular, but they are extrasynovial. We have bursa, you know the bursa. We have 12 bursa around the knee joints. The most important, we try to discuss it, are the suprapatellar bursa, prepatellar bursa, subcutaneous infrapatellar bursa, and deep infrapatellar bursa. Any one of these might be inflamed, and inflammation of bursa called bursitis. The biggest one is the suprapatellar bursa, اللي هي بالحقيقة it is an extension of the synovial cavity of the knee upward between the quadriceps tendon and the femur. And synovitis or bursitis of the suprapatellar bursa will lead to diffuse swelling of the knee and just above the patella. The other bursa, named the prepatellar bursa, it is actually subcutaneous. between the apex of patella and the skin. It is subcutaneous and it might be inflamed and become swollen and painful. And this problem, sometimes they call it house-made knee. House-made knee, which is usually due to excessive friction. The infrapatellar bursa, we have two, one superficial between the skin and the tibial tuberosity and patellar tendon, and the second one is deep between the patellar tendon and the tibia. Any one of these might be inflamed due to friction. The Clergyman knee is due to inflammation of the subcutaneous infrapatellar bursa. Even the deep intrapatellar bursa, although less common, also might be inflamed. Now we come to the injuries of the knee. The knee, one of the most common joints liable for injuries, and the commonest injury is the ligaments injury, and might affect the medial, lateral sides of the knee or even the anteroposterior stabilizers. The common mechanism of injury is occur when there is a force applied to the knee with the foot planted firmly on the ground, and this is force medially or laterally might injure the medial or lateral collateral ligaments. As I said in the previous slide, the attachment of the medial collateral ligament to the periphery of the medial meniscus. So a blow to the lateral side of the knee can tear both the medial collateral plus the medial meniscus. And opening of the knee joint in cases of severe trauma might also injure the anterior cruciate ligament. So when there is a severe trauma to the lateral side of the knee, will lead to opening up of the joint medially, which might lead to rupture of the medial collateral ligament, injury of the meniscus, and the injury might extend to lead a tearing of the anterior cruciate. They call it Unhappy triad of injury, which is a very severe injury for the knee joint. Anterior cruciate ligament also commonly injured, especially in sport activities, and it's usually occur as a result of severe blow to the knee with the joint is semiflexed during football or other sport activities. The posterior cruciate ligament can be injured, especially in cases of hyperextension injury or direct impact on the upper end of the tibial tuberosity, which might lead to rupture of the posterior cruciate ligament or anterior and posterior cruciate ligament. Sometimes both are injured in cases of severe trauma. This is a test to assess the integrity of the ligaments. This is called valgus thrust test for the medial collateral ligament. You put your hand on the lateral side of the lower limb just above the knee. The other hand push the leg laterally to assess any opening up of the joint medially. The varus thrust test in the reverse. You put your hand on the medial side of the limb just above the knee and the other hand push the leg medially or onward to assess any opening up of the joint laterally. This is the varus and valgus thrust test in a simple description. This is test for the anterior cruciate integrity called anterior drawer test. You put the knee in this angle around 70 to 90 degree, then pull forward the tibia to see how much the tibia slides on the femoral condyle to assess the integrity of the anterior cruciate. And the posterior drawer test is for posterior cruciate, is usually checked in the reverse direction. I mean, upper push the upper tibia backward to assess how much it slides on the femoral condyle. This is a simple way how the anterior and posterior drawer tests are done. Another injury to the knee is the fracture patella, which is a common problem, and the fracture of the patella will disturb the extensor mechanism of the knee because the patella is the part of the extensor muscle, quadriceps muscle, and the patellar tendon. And thank you for your listening.